Boston.
The Sickle Cell Support Society of Nigeria and the National Society of Haematology and Blood Transfusion for inviting me to give this talk, and I'm excited to present some of our work and give a high-level talk on gene editing in sickle cell disease. So I hope you can all hear me well.
Yes, Ma. Go ahead, Ma.
Okay. So I'm an investigator on a gene therapy trial, and I'm a consultant, and I sit on some scientific advisory boards for therapeutic companies that develop drugs for sickle cell disease. I plan to talk briefly on the background of sickle cell disease, just mention curative and non-curative treatments that are currently available, and then spend most of the time talking about gene therapy in sickle cell disease. As you know, sickle cell disease is determined by an abnormal hemoglobin. And this abnormality is a gene mutation in the beta globin of hemoglobin, so that instead of glutamic acid, there's a switch to valine, and that makes for a much more hydrophobic molecule that causes many untoward effects that we see as clinical manifestations in patients. We know that when sickle hemoglobin is deoxygenated, it changes conformation so that it allows neighboring hemoglobin molecules to form this 14-strand fiber. And the fiber is stiff and aligns itself in the red cell so that the red cell shows up as a sickle cell. We know very much about the molecular contacts that enable polymerization to happen. So there's this abnormal valine and normal contacts on neighboring hemoglobins that allow polymerization. And I point this out because I'll be talking about it briefly later in the talk. Sickle polymerization is a central pathophysiology of sickle cell disease. More recently, so in the early 2000s, we also became aware that there is a secondary vasculopathy in sickle cell disease. So besides the red cells, which are abnormal, the blood vessel wall, the endothelium, white cells, and platelets are also abnormal. They have adhesive molecules that make them more sticky and make vasoocclusion more likely to happen. So now when we look at sickle cell disease, we see the hemoglobin polymerization as the central pathophysiology, but we also see that there are other abnormalities that are in every patient who has sickle cell disease. Now, although this has made the picture more daunting, these other abnormalities have presented as targets for treatments and have allowed us to develop more treatments for patients with sickle cell disease. So we have hydroxyurea, which we've had for a long time, but as Dr. Achebe mentioned earlier, we now have L-glutamine, we have voxelotor, and we have Adakveo, and they've all been targeting other things in sickle cell disease besides polymerization. Now, those are all non-curative treatments for sickle cell disease. There are also treatments that we consider curative: the bone marrow transplant or stem cell transplant, and gene therapy. In bone marrow transplant, called stem cell transplant or HSC transplant, we're taking cells from people who do not have sickle cell disease, and we're infusing them into patients who do have sickle cell disease. Now, this is met with a few challenges, such as a donor pool. So we need to find people who do not have sickle cell disease to act as donors. And there's some immune incompatibility. So there are complications like graft versus host disease that we have to deal with in patients who receive bone marrow transplants. Now, in gene therapy, we are using the patient cells, which we get out from the patient, and we reinfuse them into the patient. Obviously, before we reinfuse these cells, they need to be modified in some fashion, and it's this modification that's referred to as gene therapy. So the goal of gene editing in sickle cell disease is the permanent delivery of a corrective or anti-sickling gene cassette into long-term repopulating HSCs, so stem cells that allow for continual production of these corrected red cells for the life of the patient. And the basis is ex vivo manipulation of the patient's cells. So we take cells out of the patient, we need to change them in some fashion, and then put them back in to ameliorate the symptoms and signs of sickle cell disease. In sickle cell disease, there are three flavors of gene editing. There's gene addition, where we're using a virus that has been inactivated, so it no longer has viral particles, and we're able to either put in an anti-sickling beta globin or gamma globin into the patient. Alternatively, there's gene correction, where we go and try to change or correct the sickle hemoglobin to normal hemoglobin. And then there are editing approaches that try to induce fetal hemoglobin. We've known for many decades that increasing fetal hemoglobin decreases polymerization in patients with sickle cell disease, and we try to do that in some gene therapy groups. The editing tools that are used in gene therapy include lentivirus, which is that viral that virus that simply carries the modified product into the cells of the patient. Or there are other, maybe even more advanced editing tools where these are nucleases, so they are enzymes that go specifically to cut the DNA of the patient around the sickle cell mutation and allow for a recombination that no longer includes the sickle mutation. So in our gene therapy trial, what we are trying to do, or in our program, what we have tried to do is induce fetal hemoglobin. You recall that as we move from being fetuses within the womb of our mothers to becoming an adult, there's a normal switch from fetal hemoglobin to adult hemoglobin. BCL11A is the best known repressor of fetal hemoglobin production, so it allows for that switch to adult hemoglobin. But as you know, the sickle mutation does not affect fetal hemoglobin and only shows up when we switch from fetal to adult hemoglobin. So in our program, we are trying to downregulate BCL11A to allow induction of fetal hemoglobin at the expense of sickle hemoglobin. For gene therapy in general, we take out hematopoietic stem cells from the patient. It undergoes gene editing or gene modification in the lab. We condition the patients by giving chemotherapy, and then we reinfuse these cells into the patient. For our program, what made it possible for it to progress was when David William and colleagues were able to identify BCL11A and also able to produce a lentiviral vector that could carry BCL11A into stem cells from the patient and reinfuse them. So this is our whole program in a nutshell. More specifically, we get cells from the patient. These cells are being worked on in the lab, and in the meantime, the patient gets chemotherapy. We infuse the cells, and we are following the patients for up to 2 years. This is just a picture of a patient receiving autologous gene-modified cells. to show you that it's really an anticlimactic procedure. Patients and their families are surprised that it doesn't include any surgery. The cells just go in as if it's a normal blood transfusion. For the patients who we've had in our trial, so we have 7 patients so far that we've reported on. They've had no vaso-occlusive crisis since after gene therapy, no respiratory or neurological events, no transfusions except for one patient who had a stroke prior to gene therapy and so is being transfused for prophylaxis, secondary prophylaxis. And one patient has had a recurrent priapism. The patients all have an increase in their hemoglobins and modulation of indices of hemolysis.
Hello, sir.
You may remember in 2017, the New England Journal of Medicine presented a patient who had gene therapy with a different program. So in their program, they took advantage of this molecular contact that allows for polymerization. They're able to disrupt this contact, and they were able to present their patient up to 15 months out who still had the gene product, 50% of the gene product, 50% of his own hemoglobin. He had a total hemoglobin of 11.8 and had no symptoms of sickle cell disease since gene therapy. Yesterday, I went to clinicaltrials.gov and put in 2 terms, sickle cell disease and gene therapy. It pulled up 31 studies, of which 8 were really gene therapy trials in sickle cell disease that are enrolling patients. So we're making some way with gene therapy in sickle cell disease. But as we look at gene therapy, we are aware that there are challenges that we need to try to make our way through. There are many potential gene modification approaches. We have to figure out which is best for patients. We have to continue to fine-tune our bone marrow stem cell collection. The conditioning toxicity is of concern because we're giving patients chemotherapy and we don't know what the long-term side effects will be. So far, we are delivering modified cells ex vivo, and the goal would be to be able to modify them in vivo so that the cells never leave the patient. We're not sure how to determine potency of a modified cell product. So these are still, we're just really guessing about that. We don't know how to evaluate genotoxicity. So which assays are best at telling us whether gene therapy will be toxic to a particular person? And we don't have good answers for that. Of course, the manufacturing right now is cost prohibitive. We have to find ways to stop, to make sure that only programs that have a good chance of being successful are even embarked upon. And then we have to think of equity. We are aware that with the cost of gene therapy currently, it will not get to the people who need it most. So as we look at the risks and benefits, we look at the alternatives, and we are really waiting for long-term outcome, both molecular, hematologic, and clinical outcomes. So we think that the opportunities for gene modification or gene editing therapy will depend heavily on the longitudinal follow-up that can confirm safety and efficacy of gene editing. And we need to make sure that as we are successful with gene editing therapy, that we are able to impact areas of the world, sub-Saharan areas specifically, where sickle cell disease has its most clinical impact. So we see gene editing as new and exciting with great prospects for a cure for sickle cell disease. There's been superb progress, but there are many unanswered questions. So we are aware that we must proceed diligently, and the goal is really to have a safe, simple, curative, and accessible therapies in general for sickle cell disease. I put up this slide in particular to say that although I presented this in maybe 10 minutes, it takes a village to come to this point. There are people at Children's Hospital, there's cell processing, there are all these people at different institutions with different skills and funding from the NIH that's made this possible. So I would like to thank my colleagues at where I work, our neighboring institutions that are just across the street. A lot of this work is done on the backbone of Harvard Medical School. And most importantly, to thank individuals with sickle cell disease, particularly those who agreed to participate in these trials, and for individuals with sickle cell disease all over the world who make this work worthwhile. I'd like to thank you for the opportunity to present this, and I'd be happy to answer some questions.